Hello everyone. Now today we will be discussing about nephritic syndrome. Since we have in previous lecture we have taken the overview of nephrotic syndrome, nephritic syndrome and certain terms. Now we will be discussing nephritic syndrome in details and the causes of the nephritic syndrome in detail so that we can understand what is the cause that is going to indicate, that is going to deliver, that is going to come in our questions on our board and even in the clinical management of the patient. So it is necessary not only to diagnose the nephritic syndrome, but we need to know what is the cause. That is more important. Okay, so the diagnosis of nephritic syndrome is very easy, you can easily diagnose it. But what are the causes? The causes and in which cause is responsible for this nephritic syndrome is mainly important, and that we need to know in detail. That is more important point. Okay, so previously we have discussed about this three things, that this nephrotic and nephritic syndrome is mainly due to this filtration barrier. This is the capillary endothelium barrier, then there is the glomerular basement membrane, and this is your porocyte, that is the epithelial layer. Okay, so and this is the Bowman's capsule. The filtration occurs here and the urine formation occurs. Since there is a two barrier, this was epithelial and this was endothelium. Okay, so we are talking about that since there are two barriers. One is there is the size barrier, the size that passes through this fenestration endothelium, goes to the glomerular membrane, and then there is the decrease in size, then porocyte. Then there is a size barrier, and also there is a charge barrier, that this all are negatively charged, and since negatively charged, they repel the negatively charged material, mainly the plasma protein, and albumins. Okay, so it repels out the negative charge. The albumin size is actually enough that can pass through this fenestrated endothelium. So it means that if there is no negative charges in this filtration barrier, then what happens? The albumin will leak into the urine. So, but in reality that doesn't happen, and it doesn't happen due to the negative charge present in this filtration barrier. That you have to understand. Okay, because when we damage the filtration barrier, charge barrier, then albumin will leak out, and which occurs in case of the nephrotic syndrome, which we will discuss. Okay, in nephritic syndrome we are talking about the glomerular basement membrane. So it is a inflammatory process. So this is the inflammatory process of glomerular basement membrane. The hallmark of nephritic syndrome is inflammatory process of your glomerular basement membrane, and there is bleeding. Since there is a bleeding, what you will find? You will find in urine there will be the hematuria. And if you remember my lecture of urine cast, if you have not seen, go and see it, because it is very important to understand how the urine cast form and what are the diseases associated with it. Since RBCs leak in the urine and the tan horse protein are secreted in your tubules, they got deposited, and on the deposition, that is the normal hyaline cast, they will hematuria, the blood RBC will get deposited and form the RBC cast. You will understand detail while watching that video, so please go and see that. Then we are talking about here, since there is a hallmark in the inflammatory process of the glomerular basement membrane and bleeding, the cause will be hematuria. The patient will present as hematuria. The RBC will be found with cast. RBC cast will be found in the urine, and it is the most characteristic finding of this nephritic syndrome, which will help you to differentiate from nephrotic syndrome if you are seeing a patient in a generalized way only. But since we are going in the very detail and in details of detail, so it is very overview only. But when you see and when you find a patient in your clinic, and if you are finding that it is a nephritic syndrome or nephrotic syndrome, the main point which will differentiate will be RBC cast in the urine. Even if it is in the question of the board mentioned is that, then it is never a nephrotic syndrome, it is nephritic syndrome only. That you have to understand. Then there will be associated with azotemia, oliguria, hypertension due to subluxation and proteinuria. The proteinuria will be there, but it will be subnephrotic, and that is less than 3.5 nephrotic. That you have to understand, which is contrast with the nephrotic syndrome, where it is more than 3.5 gram per day. Okay, so we are talking about, this is the finding which will be presented in the nephritic syndrome. These are the finding which will help us to diagnose the case in the board. Okay, now when we are coming from the presentation point of this, the cause will be most is, let's deal with the cause of your nephritic syndrome. The nephritic syndrome cause, if you remember in the previous lecture, we have talked about nephritic syndrome cause, nephritic syndrome cause, and nephritic syndrome cause. So, if you are talking about nephritic syndrome cause, the cause will be acute prostate streptococcal glomerulonephritis, which is known as the PSTN. Then there will be rapidly progressive glomerulonephritis, known as RPGN. Then IgA. Okay. Then there will be Alport syndrome, and there are two other diseases: diffuse polyphenol glomerulonephritis and membranoproliferative glomerulonephritis, that were responsible for nephritic syndrome and even nephritic nephrotic syndrome. Okay, so we'll discuss here two, and then we'll discuss in next lecture the others. Okay, first, the common one is the acute post-streptococcal glomerulonephritis, and it is very much important because we commonly see the patient present with a sore throat, and if it is a nephrogenic strain, then that patient will develop. First, may develop this nephritic syndrome out there, which is called post-streptococcal glomerulonephritis. Okay, what happens? This disease is mostly common in children. Right? Okay, that occurs 2 to 4 weeks after Group A streptococcal infection, and you have to remember that there is a Group A, Group B streptococcus. Okay, Group A is called Streptococcus pyogenes, and Group B is called Streptococcus agalacticae. So, if you are saying they are saying Group A, then you have to understand they are telling about you Streptococcus pyogenes, and Streptococcus pyogenes is the most common organism to cause this pharyngitis. And if there is a pharyngitis, then 2 to 3 weeks after, due to the molecular mimicry, there will be type 3 hypersensitivity reaction. That is that the group, first you understand that Group A streptococcal infection, or either the pharyngitis or the skin infection. They may tell you about the skin infection. Okay, that both will lead to this kidney damage, that is post-streptococcal glomerulonephritis, that you have to understand. Pharyngitis is responsible for rheumatic fever and acute post-streptococcal glomerulonephritis, whereas the skin infection is only responsible for the streptococcal glomerulonephritis. That is not affecting the heart. That you have to also understand hereby itself. Okay, now we are talking about the reaction. This is type 3 hypersensitivity reaction, that is immune complex. We will talk in detail about the every hypersensitivity reaction. Here we are talking about the immune complex. Immune complex, that antigen antibody both is present, and that is circulating, and when it goes and anywhere deposited and cause the damages. Okay, since immune complex is there, it will activate the complement as well. If you remember the classical pathway, in the classical pathway there is the GM, that is the immunoglobulin G and immunoglobulin M is responsible for activation of the complement pathway if they found antigen. Since here is antigen and antibody both is there, so what will happen? Their complement pathway will be activated, and since complement pathway will be activated, then there will be consumption of the complement protein, and because of that there will be decrease in complement level due to consumption. That you have to understand. Okay, what will be the other presentation of the patient? Since there will be a edema. Okay, protein is lost, and since protein is lost, there will be peripheral and periorbital edema, but it is not significantly more than 3.5. That is not in a nephrotic range, that you have to understand. Then there will be a presentation of cola colored urine. If you remember the Coca-Cola, they are mentioning about the cola colored urine. Okay, then patient will have hypertension, and this cola colored urine, hypertension, RBC cast in the urine, hematuria differentiate your nephritic syndrome from your nephrotic syndrome. I is actually I for inflammatory, nephritic. I is inflammatory. Okay, that you have to understand. Okay, to remember. Now, we also know that if there is a streptococcal infection, then there will be a streptococcus. If they may give you the history of that streptococcal infection has occurred, or culture positive have occurred, or titer has been infection, or there will be a positive streptococcal titer or serology. That you have to understand. Okay, now this is the presentation, the common in which patient it will occur. What is the organism, and there will be the name is nephrogenic strain, that is we call streptococcal infection. Okay, now coming to the point of diagnosis, what will be the presentation in your case and how we will diagnose in the microscopic point of view. What will mention in your board, that you also have to understand, and this will also will be hint in your question, and may they ask you in the answer as well. Both can occur. They give you a hint and ask another thing, or they may get you a diagnosis and ask about this. This is important actually. Okay, so there will be three findings: light microscope, immunofluorescence, and electron microscope. Let me tell you what is this. Light microscope is actually a microscope. If you have seen that we use the light, and it has the magnification of 100 or 1000 to 2000. So if anything can be magnified 2000 times, that is 1000 to 2000, that is light microscope. Okay, if you are talking about immunofluorescence is not about the magnification of the detail. It is about that there is something antigen, we put an antibody and label that antibody with the immunofluorescence. Since if something is there, an antibody get attached to it over there, it tail has immunofluorescence. Let me explain over here. Since this is an antigen, okay, now we have an antibody. In the antibody there is immunofluorescence tag over there. The immunofluorescence that can give a immunofluorescence, that we tag over here. Now if it is present, suppose we are talking about anything, we are talking about nephritis, okay, so we are talking about immune complex. So immune complex is here. Now immune complex on the against of immune complex will form an antibody. In that tail will tag the dye with can immunofluorescence, and now if it is present, then it will get attached over here and immunofluorescence will be present, and when we see in the immunofluorescence microscope, this will give a immunofluorescence. If antigen is not present, then it will get washed away in the process. So immunofluorescence is actually detection is present or not, and it is detected by immunofluorescence light. That we have to understand. Okay, and when we are talking about the electron microscope is actually, it is 10 billion time, even it can give you a 10 billion time magnification. So you can imagine how much time magnification can be occurred. So these are the three findings which we may want to know. Then light microscopes, the glomeruli will be large and hypercellular. Since I have told you there is a complement pathway activation due to immune complex, and since there is a complement pathway, the end product of the complement pathway, a lot of things. Among them, extra product is C5a, and C5a is responsible for chemotaxis of the neutrophil. So neutrophil will come more, there will be hypercellularity in the glomerulus. There is a picture in the FA, you see there will be hypercellularity. There will be this like structure, this is the Bowman capsule, there will be this space, and there will be tons of cell. This is the finding of in your light microscope. Okay, now coming to the immunofluorescence I will discuss little more well after this, because we need to understand it here. Okay, immunofluorescence, there will be three types. One is immunofluorescence that is linear, one is immunofluorescence that is granular, and one is no immunofluorescence. Okay, since we are talking about the linear, okay, then in the linear one, here is an example. In the linear one, suppose there is there is a glomerular basement membrane, it has been inflamed. Now you have put your antibody tagged with the immunofluorescence. What happened? It get bound linearly. Since there is a linearly attachment, the finding will be the picture will be clear-cut demarcated line. Okay, so there will be a clear-cut demarcated line, which you will see in your picture. Okay, so that is linear immunofluorescence, and it is a characteristic of your rapid progressive glomerulonephritis. Will come in there. Okay, then there is another called granular. So linear, granular, and no immunofluorescence. So we are talking about granular here. In a granular appearance, there will be a lumpy bumpy. Okay, so there will be a immune complex deposition over here, and due to the deposition of immune complex, the immune complex are not uniformly deposited here, so they will not be well demarcated line, that you have to understand. Okay, suppose immune complex is deposited here. Now antibody will bind here, so this part will be highly fluorescent, but it will not be like demarcated well, that you have to understand. Okay, so we are talking about granular appearance, and that is lumpy bumpy due to the deposition of the immune complex, that is IgG, IgM, C3 deposition along the Uworld base membrane and the mesenchyme. Okay, so this is important. You have to not cell, you have to understand that light microscope, the glomerular enzyme and hypercellular. In immunofluorescence, there will be a glandular appearance, that is lumpy bumpy appearance due to deposition of the immune complex, And when we talk about the electron microscope, when the electron microscopic, there will be the soft epithelial immune complex hump. Okay, so this is epithelium, this is your glomerular basement membrane, and this is the endothelium. So in the, we are talking about soft epithelial. Actually, the immune complex deposit here. Okay, then it progress, pass here and get deposit here. So while disease has been progressed, there will be subepithelial. Subepithelial deposition will be there. Okay, this hump will be there. Or say here, subepithelial hump will be there. So in electron microscope picture, it will be clearly seen that there is a subepithelial hump over there, and you have to understand about that. There will be a basement membrane. They will see you the capillary. They will give you the Bowman's space structure, glomerular structure. Now you can easily understand that towards the Bowman space, this is the epithelial layer, and in epithelial, this in the subepithelial layer, above this glomerular basement membrane, there is a hump, and this is subepithelial hump, and that is the characteristic finding of your post-streptococcal glomerulonephritis. So you have understood about why I am taking about subepithelial hump, because when we talk about another hump, there is another disease which have the same granular appearance, that is due to immune composition, deposition, and that is diffuse polyphenol glomerulonephritis. Granular appearance and immunofluorescence will be same. Now how will differentiate? Differentiated will be electron microscopic finding. In electron microscopic finding, there is a subepithelial immune complex hump in your acute post-streptococcal glomerulonephritis. But when you talk about this diffuse proliferative glomerulonephritis, that is DPGN, then there will be a soft endothelium. Here will be your hump, that is below your glomerular basement membrane, and that is main differentiation point. You have to understand that. Okay, so we'll come here about that. So we are talking about what? We are talking about acute post-streptococcal glomerulonephritis. Since look, here was deposition, it moved out towards here, then it comes into the hair, and finally it goes into the Bowman's and get disappear. So the treatment is nothing to do, just observe and manage the symptomatic. So 90 to 95% of the case will resolve spontaneously. We are talking about acute post-streptococcal glomerulonephritis, and if it is not going to resolve, then in 5% case it will progress to the rapidly progressive glomerulonephritis. Okay, and if it progresses to the rapidly progressive glomerulonephritis, then it is very poor prognosis and can be rapidly deteriorating renal function and will lead to the renal function within few days. Okay, so now I think we can easily diagnose. They are talking about most commonly in the children. Organism is nephrogenic group A streptococcus, then type 3 hypersensitivity reaction, there will be decrease in complement level. We are talking about the edema as well. There will be cola color urine. Okay, there will be hypertension, hematuria, RBC cast. These all are there. Microscopic hypercellularity, granular immunofluorescence will be positive, and that will be the granular appearance. Okay, and the immune complex diffusion. And if we are talking about in electron microscopic, then there will be subepithelial immune complex deposition or subepithelial hump, that you have to understand. Subepithelial hump. What is the how same in immunofluorescence? There is another disease which we will discuss, that is diffuse proliferative glomerulonephritis, which is the cause of this nephritic syndrome, and that will also have this granular appearance immunofluorescence. But on electron microscopy, how will you differentiate? Differentiate by this is a subepithelial immune complex of acute PSGN, but DPGN, diffuse proliferative glomerulonephritis, will have subendothelial hump. Okay, so you have, I think, clear about it. So let me. So we can divide it actually on the basis of immunofluorescence into one is linear, another is we are talking about granular, and third one is no immune complex, no immunofluorescence. Okay, so no immunofluorescence. Now linear, I have talked about it, that this is the glomerular basement membrane, there is epithelial layer, there is endothelial layer, this 3 layer is there. If there is endothelial antibody against your glomerular basement membrane, then that is a finding of your rapid progressive glomerulonephritis and mainly the good pasture syndrome. we'll talk about it. Okay, now this is the finding of your linear immunofluorescence. In granular immunofluorescence, there will be post streptococcal glomerulonephritis, that acute one, and diffuse proliferative glomerulonephritis. These two will have the lumpy bumpy immunofluorescence. Okay, and how will differentiate it? There will be a lot of features. Both are cause of your nephritic syndrome, but they are both will have immunofluorescence granular lumpy bumpy appearance due to immune complex diffusion. But in electron microscope, here will be soft epithelial and here will be in electron microscope which will be soft endothelial. I think you can easily differentiate now. Okay, we are talking about soft epithelial is PSGM and subendothelial about epithelial, diffuse proliferative glomerulonephritis. So you are clear about this also. You are clear about linear also. Now no immunofluorescence, or also known as the Pauci immunofluorescence. This means less immunofluorescence, and their example includes there is Wegener, WEGNER, Wegener. Then there is microscopic polyangiitis, and Church-Strauss syndrome. So we have discussed about this granular post-cerebral glomerulonephritis and diffuse proliferative glomerulonephritis. Although I have not discussed in detail, but I have told you how to differentiate between this. Now we'll discuss about the linear one and this one. Okay. So linear, I have talked to you that if we are not going to, if 5% of case post-cerebral glomerulonephritis will progress to rapidly progressive glomerulonephritis, which is poor prognosis, within days or week there will be the failure. Okay. Other associated with this rapidly progressive glomerulonephritis are Wood-Passer syndrome, Wegener's granulomatosis, microscopic polyangiitis, and Church-Strauss syndrome. Now we need to differentiate between them. Okay. In rapidly progressive glomerulonephritis, their light microscope and immunofluorescence will be crescent moon shape. What is crescent moon shape? If this is the glomerular structure, then certain part of your glomeruli will be normal, but in crescent shape, this part is actually damaged, sclerosed. Okay, and this crescent shape has actually consists of your macrophage and the fibrin, and that is high yield actually. The crescent shape that has damage in your rapid progressive glomerulonephritis is due to the macrophage and fibrin, and that has leads to the damage of this portion, crescent shape portion of your glomerulus. Okay, so normal portion is here, but crescent shape damage has occurred, and this damage, this formation is due to the, although there are other component also, but you have to remember macrophage and fibrin. There are the parietal cell of the Bowman's capsule. Okay, that is there. Now coming to the disease associated with rapid progressive glomerulonephritis are Wood-Passer syndrome, Wegener's granulomatosis, microscopic polyangiitis, and Church-Strauss syndrome. Now we need to differentiate between them also, which is the actual cause responsible for it. Okay, and for that what we'll do, Wood-Passer syndrome, we go back and see that in the immunofluorescence we have the linear microscope, linear immunofluorescence. So we are able to diagnose it from other as well, from this your PSGN, DPGN, because they all have granular appearance. The linear is only Wood-Passer syndrome. So you will diagnose immunofluorescence. How it will present, since it has antibody against the glomerular basement membrane. So this is type 2 reaction. The antibody towards the glomerular basement membrane and alveolar basement membrane. So there is linear immunofluorescence, I talked about it. So there will be effect of glomerular basement membrane, kidney, presentation will be hematuria. There will be alveolar basement membrane of your lung, presentation will be hemoptysis. Okay, and this is classically seen in the young adult male. There will be the clinical scenario, the young adult male present with hemoptysis and hematuria. They are talking about Wood-Passer syndrome. What they will ask about the linear immunofluorescence. Okay, you have got about it. Okay, how would you differentiate from other? The similar disease towards the Wood-Passer syndrome is Wegener's granulomatosis, with which we can get confused, because in Wegener granulomatosis also there will be the damage of your alveolar basement membrane, but there will be hemoptysis, there will be hematuria. But how will differentiate? In the history, there will be this Wegener granulomatosis is known as the C disease. In the history, there will be the feature that they will tell you about the sinus or nasopharyngeal infection. That is, you have to understand. If they are talking about nasopharyngeal infection and with hemoptysis and hematuria, then they are talking about Wegener's granulomatosis, not Goodpasture syndrome. The only history differentiation, there are other differentiation which will be there in the question or in the lab, we can differentiate it. But by history, this is lung and kidney, we are called good and affect only the lung and kidney. That this is not good because it affects the nasopharynx as well. That you have to understand. Nasopharynx, lung and kidney as well. Okay, so we are talking about Goodpasture, you have to understood. Now Wegener's, they both are similar, but one is history diagnosis, another is immunofluorescence. This is immunofluorescence positive, linear one. But these all other, the lower one, that is Wegener's granulomatosis. So we are, these two are common. So this will know immunofluorescence will be negative. You will diagnose, you will differentiate, immunofluorescence will be negative. Then what it is positive? It is positive towards the ANCA, that is Anti-Neutrophilic Cytoplasmic Antibody. Okay, so there are two types of ANCA. If you examine a slide, a neutrophil, in neutrophil there will be antibody near the nucleus, and that is known as the perinuclear anti-neutrophilic cytoplasmic antibody, and there will be towards and out to the cytoplasm, that is away from the nucleus, and that is in the cytoplasm and known as the cytoplasmic anti-nuclear cytoplasmic antibody. Okay, so these Wegener's, microscopic polyangiitis and Church-Strauss syndrome, they are actually immunofluorescence negative. Okay, since they are negative, what they are positive? They are positive for ANCA. Okay, in ANCA there are two types of ANCA, C ANCA and P ANCA. C ANCA is positive for Wegener's granulomatosis. So it is known as the C disease. To remember, C for sinus, actually S for sinus, but C also can be remembered, and sinus infection occurs in Wegener's granulomatosis, and C ANCA is positive. By these two ways you can differentiate your Wegener's granulomatosis. You can diagnose and you can deal the question. Okay, its another name is granulomatosis with polyangiitis. So I think now there will be no confusion. You can easily diagnose Goodpasture. Similar presentation can be, they may not mention you about the sinus, but if we are mentioning about the sinus, this is Wegener's. Okay, and if you are not mentioning about sinus, then immunofluorescence will be negative in Wegener's granulomatosis, positive in case of, which is linear one in Goodpasture syndrome. If they are talking about further thing, then C ANCA will be positive in Wegener's granulomatosis but negative in your Goodpasture syndrome. Okay, so you have know about it. Now let's discuss about the possible, the immunofluorescence that is negative. Immunofluorescence negative is Wegener's, microscopic polyangiitis and Church-Strauss syndrome. In them, C ANCA and P ANCA is differentiation point. If C ANCA is positive, Wegener's granulomatosis. If P ANCA is positive, then there is the two differential diagnosis. One is microscopic polyangiitis and another is Church-Strauss syndrome. Now how we can differentiate, because both are P ANCA positive. Now how we can differentiate between them? In there, we can differentiate it by the three features, that is the granulomatous inflammation, eosinophilia and asthma. These three features are present in the Church-Strauss syndrome but absent in the microscopic polyangiitis. And in this way, we can differentiate each and every cause and able to manage the patient, able to diagnose the case on the test code and score. Okay, so hope this is helpful, and this is very high lecture. It is need to be, you have to go through your first aid also. This all our information are mentioned in your first aid. Okay, thank you. Let's hope to see you in next lecture with other cause of your nephritic syndrome.